My name is Clyde Yancy, Professor of Medicine and Chief of Cardiology at Northwestern University in Chicago, and I'm here with friends and colleagues to talk to you about the results that will be released today in the fourth session of the late-breaking clinical trials here at the American Heart Association Scientific Sessions. With me are Biykem Bozkurt, Ray Gibbons, and Adrian Hernandez, really great colleagues and terrific investigators in their own right. We really are fortunate because we've got some of the investigators with us to talk about these late-breaking clinical trials. Adrian, let me start with you. There's a trial that is of interest to all of us that are in the field of heart failure. It's called Augment HF. Now, we've heard some pilot data when we were in Europe. We heard a little bit more pilot data at the Heart Failure Society of America meeting, but now we will hear some more substantial data. Give us a sense of what we can expect.
Right. So Augment HF was actually investigating a new device, actually a type of gel, that algocell, that you can inject into the heart to actually help prevent worsening remodeling. And last year at this meeting, they showed the early results at 6 months, and today we'll hear the 1-year results, which shows the durability of the intervention and also provides some information regarding its safety.
So we have to be very careful with our enthusiasm here, but we've always known that any modality that can affect what we call reverse remodeling in heart failure ultimately has led to fairly reasonable, if not good, clinical outcomes. This idea of using something mechanical to get to the same goal is very intriguing. Any sense of risk or concerns or things that are still very uncertain?
Yeah, so I mean, this is early study, so certainly we see improvements in exercise or functional ability through CPX testing, but you never know in terms of what's the long-term outcome, such as mortality. And so with small numbers, you can also see differences between the intervention group and the control group. And so a future study will need to really understand that benefit-risk ratio.
So recently we've been using biomarkers as a surrogate of clinical outcomes. Do we have biomarker data that we can take a look at?
In this study, we don't have biomarker data. It's really focused on exercise capacity, 6-minute walk, quality of life, NYHA class.
So work in progress, stay tuned, but so far so good, and we'll see where we go from here.
That's right.
That's great. So Biykem, you've got some data that you'll be sharing with us on a very different kind of drug class, going back into the beta agonist mode here. You know, we get confused. We talk about beta antagonists, and now we're talking about beta agonists again. So kind of help us understand BEAT HF.
BEAT HF is a very innovative single-center randomized clinical trial conducted in Denmark in approximately 70 patients with mirabegron, which is a beta-3 agonist. And this is a representation of the new line of beta-3 agonistic agents that has been approved for overactive bladder treatment, both in Japan and in USA, but with the recognition in some animal models that if were to be given in pressure overloaded hearts, may attenuate the heart failure phenotype. So this resulted in the first phase 2 trial with a determination to find out whether it would improve the heart function. Perhaps the hypothesis behind the concept was in the sodium overloaded hearts with the beta-3 agonism through the sodium-potassium channel pump, the agent would be able to move the sodium along with the calcium out and prevent calcium overload. But interestingly, the primary endpoint, which was ejection fraction, did not change. Neither were the secondary endpoints, which were mainly exercise capacity and reversal of remodeling. And part of that would be to question whether the hypothesis, as you alluded to, had a bimodal effect, as proposed perhaps in the failing heart, as seen in the normal heart. Maybe there was some negative inotropic effects. And the study was quite small, underpowered, and probably these agents will require further characterization, both in experimental models and the heart failure population.
So even though the results are negative or neutral, and we hesitate when we use those words because there's always something to learn from a study, what do you think are the take-home messages in this exercise or in this research?
Number one is perhaps agents that has bimodal effects are difficult or challenging treatment modalities in the heart failure phenotype, especially when we know there could be a transition from an acute to a recovering heart failure, as well as ejection fractions are not a single target and could be in the spectrum of severely depressed to borderline depressed. Thus, agents that may be detrimental in a normal heart or beneficial in a failing heart or vice versa would be difficult to target in the heart failure population because we're not dealing with a single phenotype. The second concept is cross-reactivity with the other receptors, beta-1 and beta-2, would be of concern as such that it could potentially have toxic or harmful effects, and tachycardia and ischemia would be of concern. So going forward, I think translational studies first need a characterization, experimental models, and perhaps we would like to know more about the cardiac mechanics and hemodynamic effects, and then transition into phase 2 and subsequently large-scale clinical trials to determine both safety and efficacy.
So it is complicated. You know, Adrian, this is yet another example of a number of trials here with new novel agents in heart failure, and we just have to recognize that it's a difficult path to go. We looked at the soluble guanylyl cyclase inhibitors or activators, and we've looked at new anti-diabetic agents, and we even looked at long-acting nitrates, and we get signals, we get hints, but not much more than that. So
it's definitely challenging. Yep.
Yeah. So, Ray, you've been around as long as me, if not a little bit longer, and you and I have seen a lot of drugs come and go for different indications. But now we're looking at Ranolazine. I mean, you just heard Biykem talk about an agent that has a lot of complicated pharmacology. Let's introduce ourselves to Ranolazine, which is another one that's got some unusual pharmacology, but used in a very different way in the data that we're going to see.
Well, the session today is called Novel Therapy for Common Problems. Certainly heart failure is a common problem, but another common problem is so-called microvascular angina. The WISE study, an NHLBI-sponsored trial, showed us that many women in particular can have ischemic syndromes without obstructive coronary disease and have abnormal coronary flow reserve when properly assessed. Following the publication of those results, the trialists in that group have had a number of studies which have explored potential mechanisms and potential therapies that might be beneficial to such patients. Certainly the mainstay of therapy are nitrates and calcium channel blockers, but in patients who continue to have symptoms despite those drugs, there are a variety of other agents that are often tried without solid evidence, and one of those is Ranolazine. So the WISE investigators managed to get commercial funding for a carefully done study of Ranolazine in women with microvascular angina. Somehow or other, one man sort of snuck into the protocol, but 96% of the subjects were women.
That's another story.
That's another story, presumably. They carefully investigated in a double-blind fashion and a crossover fashion whether Ranolazine brought benefit to a number of different measures of angina. And the answer was it didn't bring any benefit. Rather than think of it as a negative trial, I think it's an important trial to show that one of the empirical therapies that clinicians have often utilized actually doesn't work when it's carefully investigated. So hopefully that'll turn attention to some of the other drugs and lead to other studies of those drugs to try to develop the evidence for how best to take care of this class of patients who are numerous and about whom guidelines say very little because there's very little evidence as to how to manage them.
But if we make certain that we're clear on this, for those persons with microvascular disease that may be the culprit substrate for their angina, Ranolazine didn't work. But for those with epicardial coronary disease, we do have a different data set.
Right, and that's one of the interesting things. In patients with obstructive coronary disease, the approval studies for Ranolazine showed benefit. So it certainly works if you have obstructive coronary disease to reduce angina. But in this subset of patients without obstructive disease, it brings no benefit. Once again, showing that they're different from a pathophysiologic standpoint from patients with obstructive disease.
You know, there's another trial that's being discussed today that I think is important to all of us because it's about women who have breast cancer and are receiving chemotherapeutic drugs and unfortunately are at risk for the consequences of those drugs, which sometimes is LV dysfunction and even clinical heart failure. And I think all four of us have agonized when we've seen these people. It's distressing that they're dealing with a diagnosis of cancer, typically at an early age, and now someone adds on the diagnosis of heart failure. So I think it's really important that finally we're getting some randomized data and a reasonably well-done trial to try to answer whether we can preempt some of this injury. So the trial is called Prada. What can you tell us about Prada, Adrian?
Yeah, so this is an important area because one of the worries is that now that we have new therapies for breast cancer that can be highly effective, the concern has been whether they can cause cardiomyopathies. And so in this study, the goal was to see about preventing any problems in terms of developing a cardiomyopathy. And with an ARB, canasortin, they were able to show that. Interestingly enough, they didn't see any differences with a beta blocker, metoprolol.
So, Biykem, what do you think about that? I mean, we're enthused that there is a hint that we may be able to retard this consequence that can be so disheartening, but a differential effect of neurohormonal antagonists. On the one hand, the RAS blocker worked, perhaps, but the beta blocker didn't. What do you think about that?
And the mechanisms implicated in myocardial injury with chemotherapeutic agents have been in quite a wide spectrum. Oxidative stress, direct myocardial toxicity are probably more predominant than the overall heart regulation, heart rate, and or myocardial oxygen consumption. Of course, this is not to state that one is more prevalent or important than the other, but the spectrum of perhaps the injury that we see with the chemotherapeutic agents creates the challenging question as to when and how. And in this setting, the ARBs, which may have a different effect, perhaps at the myocardial or myocyte level, rather than their neurohormonal antagonism, may have played a role, perhaps differentiating its beneficial effects than the beta blockers. And then the other concept to keep in mind is beta blockers are usually very, very helpful when the phenotype of the heart failure is quite obvious, perhaps at the level of the O2 consumption. So at the early phases, before the phenotype happens, maybe the direct myocyte protection reduction, RAS blockers may be more beneficial.
Right.
I think we should remember that the patients who were enrolled in this study were really low risk. They specifically excluded any patients with prior coronary artery disease, for example. And the magnitude of the benefit in ejection fraction was really quite small, 2 points. And it was confounded by the fact that the blood pressure was actually lowered, which you might imagine, in the ARB group and not in the beta blocker group. So this may simply be loading on a normal ventricle, creating a change in the measurement. So we clearly need more data, but I think it's very, very important that in this emerging field of cardio-oncology, we actually do trials. Because until now, we just have some observational data from relatively small studies, and that's the basis for empiric therapy, which may or may not do anything.
And you know, there's a lot of that empiric therapy going on right now, Ray.
Absolutely, because everybody has seen so many patients in their practice with intensive chemotherapy develop cardiac problems, breast cancer and other cancers as well. So many institutions like my own have created cardio-oncology clinics which are actually delivering all this empiric therapy. So I think we need trials like this, and the investigators are to be applauded because although it's a small trial, this is the largest trial done to date in this very, very important area. Another common problem, cardiac problems after breast cancer.
So, you know, Adrian, just one more thought about this. Wouldn't it be nice if precision medicine could become a reality? Because you give all of these low-risk women 32 milligrams of canasortin, the very highest dose, for a very small gain.
Right.
So it would be great if we could, while we're evaluating appropriately new concepts to attenuate the injury, identify in whom and why. So whether it's biomarkers or some type of omics I think we need to get there.
Right. I mean, ironically, for oncology, they are leading the field in terms of delivering precision medicine. So we actually need to take those learnings and apply it in cardiology. And what a better setting than cardio-oncology to do so. So looking for those who are at the highest risk to have targeted therapies to make sure that they have the maximum benefit.
Well, it looks like, once again, another late-breaking clinical trials at AHA Scientific Sessions is going to be replete with really outstanding information. Some of it is disappointing, some of it is encouraging, but that's why we do the research, so we can address the answers that we need to understand better to take the kind of good care of patients that we all expect to be able to do. This is Clyde Yancy with Adrian Hernandez, Biykem Bozkurt, and Ray Gibbons here at AHA Scientific Sessions 2015. Thank you for your attention.